happy to have Dr. Clay Wertheimer with us from Everett Bone and Joint. Clay is an orthopedic surgeon in town here. Clay, how long have you been practicing orthopedics?
It's scary, but I think I've been here almost 20 years now, Shannon.
20 years, yeah. That's about the time I got to know you, about 20 years ago. So, you've seen a lot of advancements in techniques and surgical procedures, I would gather.
Yeah, in the 20 years that I've been in practice here, things have advanced quite a lot, especially with using like you said earlier, the scope or the arthroscope to help hurt knees. Okay,
so we're talking about knee injuries, and particularly with ski season upon us and almost finishing off. Have you done any ACLs this year since ski season's happened?
I have, as a matter of fact, yeah.
And how many of these do you do in a particular ski season, would you guess?
Probably do one or two a month. During the ski season.
And why ski then? That's my question. Why ski? I've been skiing once in my life, and
how'd you do?
I fell in ways I never thought were possible.
Did you have jeans and gaiters on?
You know what? Actually, I came prepared. I rented skis. I had on jeans, and I just sprayed that waterproof spray on it. Didn't really work, and it was horrible. They wouldn't even. Yeah, at one point I was going backwards down the hill, and I knew right then and there that I should not be skiing. I have a question, though, as far as the ACL injury. Normally, when you hear the ACL injury, it happens in football a lot, that you're gone for the year, right? Is that still the case? Is technology better for ACL surgeries?
Yeah, more technology's gotten better, so has the rehab. We've gotten smarter about how to get athletes back up and going after an ACL reconstruction. But it's still a pretty big surgery, so the minimum amount of time it takes to get back up to full speed is about 6 months after an ACL reconstruction. So it's still a big deal. You can't make the body heal any faster than it's capable of healing. So we're just about at that point.
So is that for the athlete 6 months?
That's for the athlete.
Okay, how about just for like,
for a guy like you?
Yeah, exactly.
Yeah, okay. Well, maybe
years.
18 years.
Yeah, probably.
Typically for the average person, realistically, it's 9 to 12 months for complete recovery after surgery.
Wow.
Can you tear your ACL on a treadmill, by the way?
I don't know, but we should ask Maury.
Yeah, we should ask Maury. So
my ashtray fell down. Sorry.
Yeah. So Clay, what exactly is kind of in layman terms, what is the ACL?
Yeah, the ACL is a rope, basically, in layman terms, Shannon. It's connects one end of the bone to the other. So it connects your thigh bone to your shin bone inside your knee joint and keeps the two together so you can do things like fall off a treadmill or ski.
Right. So basically, essentially, it keeps those two bones from moving too far against each other.
That's right.
Okay.
Yeah. So it constrains them and allows your knee to bend and twist without going too far.
So if someone was to tear an ACL skiing or falling off a treadmill, kind of signs and symptoms, what would they experience or hear or feel?
Right. Well, the first thing they feel typically is the rope breaking. And oftentimes patients will say, wow, I heard this really weird pop. All of a sudden, bam, it was like it can be really loud, and people in the gym or even in the sidelines can hear it. So that rope breaks. And then after it breaks, then there's a reaction to that damaged ligament. So there's usually
screaming.
Isn't
there screaming?
Yeah, there's
involved?
some screaming. Okay. Yeah, and so the knee joint becomes swollen. It hurts, and it can often feel unstable after that. So folks initially can't put their weight on their leg or their knee. And after the initial swelling goes down, oftentimes they'll say, "Wow, my knee feels, weird. It gives out, or, it gives way."
So there's when they put weight on it, particularly when they weight bear or twist or move, a lot of times it'll feel like it wants to give out.
Exactly. This rope really comes into play when you're changing direction. That's when it really grabs on and holds things together. So when people change direction, twist or turn, and the rope's not there, they really feel it, and the knee will feel unstable.
Right. So, like, for example, Tom Brady, we all saw the picture of him getting hurt early in the last season. I think a defensive lineman kind of rolled into his knee and kind of hyperextended or forced it backwards, and that's another way you can injure your ACL.
Yeah, typically what happens is the tibia or shin bone gets actually forced or shucked forward, and that's what happened when that big lineman rolled on his leg. It pushed his shin bone forward and just stretched out the rope more than it could take.
Right. So you've been at this 20 years and have seen a lot of changes, a lot of advancements. Like you said, you're doing all these surgeries through the scope now. Explain what treatment today versus maybe 20 years ago when you first started is and what the expectations are for the patient.
Okay, well, first of all, in terms of the treatment differences, now we, exclusively use this thing called an arthroscope. So it's basically a periscope that through two little poke holes in the joint, we can move into the knee joint and look, and it's connected to a camera that's connected to a TV screen. So we can actually look inside the knee and know what's going on inside there without having to cut it open. Years ago, when I first started, a lot of the ACL reconstructions were doing through an open incision, actually having to cut the knee open. So without having to cut the knee open, it makes healing time a lot less. And with the instrument of the scope, we can really see very well in there. And we've developed other instruments that allow us to essentially operate through poke holes while looking at a TV screen using this periscope or arthroscope. So it really cuts down the amount of invasion, if you will, that we have to do to the joint to get things done.
Which in turn was less rehab time, quicker recovery.
Yeah, it means less pain. There's less cutting and less pain for the patient and quicker rehab time.
Is there any instances for an ACL where there's a choice between surgery and non-surgery?
That's a great question. I mean, some people don't need their ACL, and there are people that maybe are sedentary or want to do just straight ahead things. They're willing to just ride a bicycle or jog. Then
I'm
they'll
straight
do
ahead.
Okay. Yeah,
I don't look behind. I am all straight ahead.
But kind of those crooked, twisted guys like me and Shannon who still like to get out there and run and twist and change direction or ski, then you really do need an ACL in your knee to stabilize it to do those things.
So are you predominantly doing what we call patella tendon or using the hamstring as a graft these days?
These days, actually, I do primarily hamstrings because the hamstrings, the technology for fixing the hamstrings has gotten a lot better. I should try to explain to the audience that, what we do, we don't repair the ACL. Once this rope tears, it's shredded. It's like no good. It's like two mop-ins. And we've learned from previous experience of trying to sew it together, that just doesn't work. So we take the old rope out and replace the torn rope with a new one. We reconstruct it. And to do that, we have to rob Peter to pay Paul. We have to take some tough tissue that your body can get rid of that'll act as a new rope. And traditionally, that's been the front of the knee, the patellar tendon, the tendon that runs under your kneecap, or the hamstrings. Both of those tendon sources are kind of redundant. You've got a lot of strength in them, and you can give up some of it without hurting your knee function. So surgeons typically use one or the other, and my druthers lately has been to use the hamstrings because I think it hurts less, it works just as good, and there are other advantages in terms of how you can fix it now and make it real strong.
That's great. That's great. I know all the ACLs that we're seeing are mostly hamstrings today. And like I said, just the rehab time is significantly enhanced with the scope techniques and just the decreased irritation of the tissue, swelling, post-op. 20 years ago, you used to put these folks in a brace.
That's right, or even a cast.
Yeah, cast.
That, people would cast them because they were afraid, we don't want to move them too quick because it might stretch things out. And that was true because our technology of fixing the ends of the rope were limited, but now we can fix the new rope really solidly so we can get people moving right away without worrying about stretching it.
Do you have to use live tissue, or is there something, fake, something that you can buy on, what I mean?
God, you guys are pretty smart. I didn't think guys in radio were that.
We watch TV.
CSI.
House.
Tom's watching CSI.
Yeah. House.
Tom, that's a great question. I mean, that's another alternative is to use what we call allograft or some other tissue, a dead person's tissue that gets harvested and preserved.
And more there's not a business for that. Don't even think about it.
Yeah.
So there's nothing artificial. You can't use rubber bands.
Like that fake crab
right,
that they sell.
There's nothing as good as real live tissue as far as the biomechanics and the strength and resiliency. There's no Gore-Tex or anything like that.
But they tried that didn't they try that about 10 years ago, a Gore-Tex ligament?
Yeah, and it was a big failure. I mean, it just fell apart, and all the fibers got caught in the knee joint, and it was not good.
Yeah.
And in terms of Tom's question, I mean, there are people that still use allografts. The advantage, obviously, is you don't have to take out the tissue from the patient, and that saves surgery time and recovery time. But the disadvantage is it's somebody else's tissue, and your body might react to it, and you may get somebody else's infection or virus. So that's my own prejudice. I don't really like to use that strategy, but that's definitely a strategy that's used and it works.
How do you stay up on the latest and greatest techniques, and do you have to do continuing education, and do you guys go to weekend seminars where you learn how to scope and
Well, actually, we listen to KRKO.
there you go, exactly. Yeah. Health matters. That's exactly what you.
I was going to say, do they talk about that on the golf course?
Yeah.
Well, we are required by our own, specialty orthopedic surgeons. They have to get so many CMEs a year to stay up on things, and by the state. So yeah, we do keep up. We go to seminars, go to yearly conferences, and you got to stay up, because if you don't, you get left behind. Because things are changing rapidly enough that in order to provide patients with the best way to go, you have to stay up with it. So,
So there's a hope for Maury then?
Yeah, there's a hope.
Yeah, there's hope. Yeah.
There's always a hope.
Watch the treadmills. That's the bottom line. Watch the treadmills.
I will. I'll try. More with Dr. Clay Wertheimer as Health Matters continues on KRKO 1380.
KO Radio.
It's Health Matters on Northsound 1380 Radio. Maury Eskenazi along with Shannon O'Kelly, Tom Lafferty, and our guest, the star of the show, Dr. Clay Wertheimer, orthopedic physician from Ever Bone and Joint. And we're going to talk right now about chondromalacia.
That's right, Maury. Chondromalacia is a big word that actually just means irritation or softening of the cartilage behind the kneecap, otherwise known as patellofemoral syndrome or patellofemoral dysfunction. And Clay, this is a whole big universe for physicians dealing with anterior knee pain and chondromalacia. Can you describe what chondromalacia patellofemoral symptoms are?
Yeah, it is a big universe, and the word chondromalacia, it's kind of like saying sports. I mean, there's so many different varieties of chondromalacia. Chondromalacia, it's doctor talk, it's Latin. It means chondro, cartilage, malacia, softening. So originally, doctors figured that people had sore kneecaps because the cartilage that was under their kneecap got soft and was the source of pain. And that is one source of kneecap pain, but there's lots of different causes of anterior knee pain other than chondromalacia.
Well, particularly, in my practice in physical therapy, we see a lot of these young kids that come into the practice, and they've gone through these growth spurts, and they have this muscle weakness and this kneecap problem, and they have problems up and down stairs, squatting, running and jumping. And what's going on there, you think?
Yeah, I think, Shannon, first you got to appreciate how much force is put on your kneecap. Like, these computer guys are figuring out, making computer models of the knee now, and in their equations, they're figuring out that you put 6 to 7 times your body weight across that joint between your kneecap and the end of your thigh bone when you're going up and down stairs, and probably more than that when you squat. So these kids that are doing that repeatedly over and over again are putting a tremendous amount of force on their kneecap and on the groove that the kneecap slides on. And if that muscles that help control the kneecap fatigue or get tired, then the force is even increased more. So I think that's why it hurts, a big part of it. Some of those kids may have some problems in that they were born with, or they're more prone to getting these kneecap pain problems because the kneecap doesn't quite fit right in the groove, or as it moves back and forth in the groove, it gets pulled to one side or the other, and that just increases or concentrates the force on their kneecaps.
Is it true? Do a lot of your patients describe kind of a cracking and popping and what we call crepitus?
Yeah, a lot of times people will have a crunchy, grindy feeling in the front of their knee as they move their knee back and forth.
Yikes.
You don't have that anymore.
No, that's not good. Crunchy grinding is not good in my knee.
So, in today's world, how are you treating and what are you prescribing for these folks with chondromalacia?
Yeah, well, a lot of times it depends on the folks. For, again, us old guys that are sitting here in the studio, that crunchy, grindy is due to arthritis and wear and tear of the cartilage. And so taking anti-inflammatory medication, strengthening your knee, stretching it so it doesn't get stiff, that's important.
It's all about ice and ibuprofen, right?
Yeah, that's a big part of it. It can really help. Vitamin I.
Yeah.
The other, for that other population you were talking about, those young kids, part of it is recognizing the training error, or what they're doing that's overdoing it.
Right.
And controlling that.
So modification then.
Modification, yeah. The other part of it is recognizing any underlying problems with how that kneecap is tracking. And that's where your people can come in with taping programs and strengthening programs. That's helpful.
So there's really no surgical approach, a good surgical approach to patellofemoral condylomalacia. It's just strengthening, modification of activities. And will a lot of these kids kind of outgrow this, and as their muscles catch up and their body catches up?
I think a lot of them will, yeah. I mean, for that population that have anterior knee pain, you're right. Surgery is not a good idea. For the type of kid that Maury had in his gym class, in that case, surgery is a solution and can keep that kneecap from recurrently coming out and dislocating.
So the bottom line for all those folks out there that might be experiencing this anterior knee pain with activities such as up and down, squatting, I mean, probably rest and ice is probably a good prescription.
That's a good place to start, and then look at, critically what you're doing that's making it hurt and adjust that. And the other thing is, see a doctor if it's really not responding to that approach, preferably an orthopedic surgeon, and get it checked out and treated.
Boy, and this is an all-day topic, Maury.
Yeah, I know. I just wanted to say we have a phone call.
Oh, excellent.
We're going to the phone, and on the phone with us is Shannon from Everett. And this is something I want to know what it is, shin splints and knee pain. Shannon, how are you? Welcome to Health Matters.
I am well, thank you.
Oh, Shannon, this is
Shannon O'Kelly, I'm sorry, and Dr. Clay Wertheimer is with us here today.
Good evening. I'm calling in that as a track coach, we run into a lot of shin splints. And I'm wondering, what is our best defense against it?
Shin splints, and is this early on in the training? I mean, are you just getting on the track right now?
Today was our first day, so probably I would say in the next 2-3 weeks we'll start hearing about it.
Right.
And do you see it in all your athletes, Shannon, or mostly the longer distance athletes? Is there a particular group?
It varies. Usually our jumpers, our sprinters, are the higher training athletes, but our distance people as well, just in that they've got the greater mileage out on the roads and things.
Yeah. Well, a big cause of this.
Can we go to square one?
Yeah.
What is shin splints?
What are shin splints?
Yeah. Well, I was just going to ask Clay, maybe anatomically, what can you describe shin splints or tibial stress syndrome?
Sure. Yeah. Well, Shannon, as you know, the shin is your tibia, that bone that connects your knee to your ankle. And there are really several causes of what we call shin splints, and three major causes. One is inflammation of the soft tissues and the muscles and tendons that attach to your shin and then go down and control and support your foot and ankle. The other is actually a stress fracture, where the bone is actually getting cracked and failing. And then the third is, in more rare, where the muscle compartments around the shin fill up with blood and swell so much that it squeezes the capillaries and starves the muscle in turn of oxygen. And they get what we call a compartment syndrome. The most common cause of so-called shin splints or shin pain is the first cause I mentioned, where there's inflammation of the soft tissues around the bone.
As we're just starting out, is there anything that I as a coach can incorporate into my warm-up to kind of lower our risk of that becoming an issue?
You know, Shannon, I think the most important thing is to get your athletes to train and keep in shape before they show up for tryouts.
Shannon, are you working on a warm-up routine? Obviously, being a coach, I mean, you want to warm these kids up, take them through some flexibility exercises, and then maybe stretch them after they run. And more importantly, if they do have symptoms, are you getting them ice at home at night?
That is usually our first suggestion, which as far as to speak to our workout, normally we do a very light jog to begin with, then we do some dynamic stretching, going into strides and kind of working up to more vigorous exercises. As far as if someone tells me they have shin pain, my first call is for ice and to kind of try to find out how bad it is, if it's something that we can change workout-wise. But I don't know.
Do you have an athletic trainer at your facilities?
We do.
That's excellent. If you do have an athlete that you suspect is becoming more irritated with activity, definitely get them to see the athletic trainer, because they can maybe do some taping techniques or even look at their foot mechanics. I mean, maybe their foot mechanics, they might overly pronate or have significant changes in their gait or the way they run that can be addressed with maybe some taping or some type of supportive device. But this is Clay, this is a situation that needs to be taken care of right away, because it can become chronic.
It can become chronic, and then the second cause of shin pain, that stress fracture, can become quite serious and debilitating. And it's particularly important, Shannon, in girls. And there's a thing that we recognize in orthopedic surgery called the terrible triad, where young girls have eating disorders, so they're not getting enough calcium and vitamin D, and their bones aren't strong. And then they're trying to be high-level athletes, so they're pushing themselves hard. And then they're not menstruating, and that screws up their estrogen cycle, which in turn is important for their bones. And that is a subclass of shin splints and athletes that's very, very serious and needs to be screened for and paid attention to. So I think Shannon's suggestions are good. My thought about shin splints basically is most anterior shin pain in athletes is due to training error. It's overtraining, either going too fast, too soon, or too much.
And surface type, too.
Yeah.
I mean, sometimes running these kids on hard surface or changing surface activity. And also watch out for these athletes that come out with new shoes. I've also seen over the years that the new shoes coming out, they're a little more rigid, and all of a sudden they put more stress on those shin muscles or that soft tissue in the shin, and it gets irritated.
I'd always do that. I'd always have that pain the first day of football practice because I would wear my new shoes. Like, I wouldn't break them in or anything like that.
Absolutely.
Sorry, Shannon, just one other thought is knowing high school students, you may, if it's possible, get them to start jogging or running a little, before tryouts.
Preseason conditioning.
Some preseason conditioning.
Yeah. And we have like 2 seconds left, so ask your last question here.
It was just real quick regarding the transition from just regular running shoes to sprint spikes. Anything we can do, toe raises, alphabets with your toes, does any of that help offset any shin pain?
I think any type of, again, preseason flexibility or early dynamic flexibility stretching prior to the event is going to be helpful.
Shannon, thanks for your call.
Hey, Shannon, good luck to you in your season.
Thanks very much.
So, Dr. Wertheimer, thank you so much for coming. How does someone contact you at Everett Bone and Joint if they have a question?
Well, they could just call me at my office, 425-339-2433. They can go to our website and learn more at everettboneandjoint.com, and I'd encourage them to do that.
Thank you.